Great. I hope everyone's enjoying their break. We've just come to our second lot of 3-minute theses presentations for today. So we'll be hearing from Ali, Emily, and Jay. Please, Ali, Emily, and Jay, if you wouldn't mind turning on your cameras. And whenever you're ready, Ali, we'll get you to start. Just a reminder to our presenters that at the end of 3 minutes, we'll be moving on to the next slide. So please keep to time.
$300 million. So we might not be able to go on luxury overseas holidays at the moment, but just imagine what you could do with that. That's how much is estimated could be saved each year by stopping inappropriate knee replacements. So guidelines around the world concur that everyone with hip and knee osteoarthritis should be receiving exercise, education, and weight management. Yet over a third of people on Australian wait lists for surgery haven't tried physiotherapy for exercise or weight loss. To try and address the gap between guidelines and practice, specialist osteoarthritis services have been set up with different models across Australia. Now, we know there are multiple barriers to people receiving appropriate care, but we don't know whether physiotherapists working in specialist osteoarthritis services face the same issues. And so we asked them. I interviewed 19 physiotherapists working across 3 states and asked what they thought influenced how people with hip and knee osteoarthritis are managed. And it turns out, whilst the models of care in the different states vary, the issues are all pretty much the same. Navigating the roadmap of referral pathways was complex, both within health services as well as externally. Pathways are influenced by things such as patients' age or comorbidities, as well as funding and internal processes. There was the view that whilst care provided by GPs was often suboptimal, wasn't necessarily their fault. There's just no options for them to refer to. If GPs did go down the road of referring to physiotherapy via chronic disease care plans, the care provided was generally considered insufficient and of poor quality. Weight management was challenging, both for patients to do, but also for the physios to arrange help for. Patient misbeliefs around osteoarthritis, such as bone on bone and expectation of surgery, were common, often set by GPs or surgeons, and difficult to change. So across all the models of care, we found barriers at multiple levels. GPs were perceived as important, both in terms of influencing patient beliefs, but also their referral decisions. So the next step is to ask GPs what would help them refer people for appropriate care and go down the road to appropriate management, and then develop a tailored intervention from there. And then maybe, just maybe, we can help people avoid an operation they don't need and save the health system $300 million along the way. How fantastic would that be?
Thank you, Ali. Our next presentation will be by Emily. Thanks, Emily.
The influence of GLAD on physical activity in people with knee osteoarthritis, a qualitative exploration. We have a problem. There are millions of Australians with knee osteoarthritis, and this means these people have physical limitations, pain, poorer quality of life, as well as reduced physical activity compared to their healthy counterparts. Exercise and education programs are well known to improve many of these impairments. However, it's not well known what impact they have on physical activity levels. We conducted a qualitative study to explore the influence of Good Living with Osteoarthritis Denmark, or GLAD, on physical activity participation, readiness to increase physical activity, and barriers and facilitators of physical activity in people with knee osteoarthritis. We conducted 19 semi-structured interviews guided by a theoretical domains framework and used inductive thematic analysis to extract themes. Descriptive analysis revealed 5 themes. Firstly, beliefs around physical activity and exercise therapy, which included fear avoidance and previous experience and beliefs about physical activity. For example, participant 8 said, "I wasn't attempting any exercise on my legs. I wasn't even going there because I was just too worried about incurring more damage." Secondly, influences on knowledge and beliefs about physical activity and exercise therapy, which included health professional education and advice and online information. Participant 14 reported, "I probably haven't received any education about exercises. I mean, the only thing the surgeon ever said to me was, 'I'll see you when you're ready.'" Thirdly, the influence of GLAD is inconsistent. Participants experienced varied physical activity and exercise therapy engagement following GLAD. Fourth, ongoing barriers of physical activity, which included persistent pain and comorbidities, lack of opportunity, lack of motivation, and cost. And finally, ongoing facilitators of physical activity, which included change in knowledge and beliefs, increased confidence, increased motivation, and external supports such as technology and social supports. For example, participant 18, who said on the screen here, "Yes, the program did help me. The benefits are mobility and more confidence in trusting my leg. And as I said before, the understanding that exercise is not to be shied away from." Our findings reflect that GLAD may address some existing barriers to physical activity in people with knee osteoarthritis, including misinformed beliefs about the benefits and harms of exercise, as well as the confidence to engage in more occupational and recreational exercise. Motivation to change and actual change in physical activity varied between participants. This suggests that in order to combat the issue and increase physical activity levels in people with knee osteoarthritis, we may need additional targeted behavioural interventions.
Thank you, Emily. Our final presentation will be from Jay.
Thank you, Sid. Are you ever suspicious that the WOMAC function score for your patient with knee osteoarthritis might not reflect their actual function when they are unobserved, like when they're at home? Perceived function seems to be a different measure of function than actual physical performance. Even performance tests like the 30-second chair stand test, which does assess performance, doesn't represent how someone actually performs the activity outside of a clinical environment. Perhaps a sensor-based system could objectively monitor functional activities when the patient is away from the clinical laboratory, such as when they're at home, so we know how often or how long they perform an activity. But sensor monitoring creates very large unlabeled data sets, so we don't actually know which activities are represented in the data stream. We wondered, what if we had a sensor system that could recognize activities in people with knee osteoarthritis when they're unobserved? Activities like walking, negotiating stairs, and transitioning to or from a chair, as recommended in guidelines for assessment. We had this great idea, but none of us knew how to execute it. Luckily, I was introduced to Dr. Beheshti at the Curtin Institute for Computation. He introduced me to the idea of machine learning, which is a form of artificial intelligence. Human activity recognition is a branch of machine learning that can be designed to automatically learn to classify activities via feature recognition. So we recruited 18 participants who had a BMI less than 30 and moderate activity limitation on the ADL function subscale of the Coos questionnaire. We placed 2 inertial measurement unit sensors on both legs over the lateral thigh and medial shank. These inertial sensors have a triaxial accelerometer, gyroscope, and magnetometer that can sample it at 100 Hertz. We asked each participant to perform multiple repetitions of 5 activities that included ascending and descending stairs, walking, sit to stand, and stand to sit. Some of them are shown here. The data was then downloaded from the sensors and processed into these rectangular images you can see. You can think of these images as just a color-coded representation of numerical values from each sensor during the data collection window. We then trained the model using the equivalent of a bootstrapping sampling method. We tested the model on data and then we tested the data. We then test the model on the data that it has never seen before. Our system had an average accuracy of 85% for identifying which of these 3 activities a person was doing: walking, using stairs, or negotiating or transitioning from a chair. If someone was transitioning between sitting and standing, the system was 97% accurate for identifying if a person was doing a stand to sit versus a sit to stand. Also, when using a staircase, the system was 89% accurate for identifying ascending versus descending stairs. This is the first study to report the development of human activity recognition system designed for people who have knee osteoarthritis. With further development, sensor-based machine learning systems like this could be used for objective home monitoring of physical function in people with knee osteoarthritis. Thank you.
Thank you once again to all of our presenters across both days. A reminder to everyone that the winners of the 3-minute thesis competition will be announced tomorrow. Our next session will be occurring at 11 o'clock and it will be happening live.